Hi, this is Dr. Poole. This talk focuses on the pathology of viral encephalitis as a complement to the presentation on meningitis and brain abscess. It's important to remember that encephalitis is an inflammatory condition of the brain with many etiologies. There are several types of encephalitis that are immune-mediated, including the classic paraneoplastic encephalitis syndromes associated with cancer, and the encephalitis syndromes associated with antibodies against neuronal cell surface or synaptic proteins, which are collectively referred to as autoimmune encephalitis. So I'm just going to focus on viral encephalitis and again refer to Dr. Richard's material for discussion of specific viruses that are involved in encephalitis. The presence or absence of normal brain function is the important distinguishing feature between encephalitis and meningitis. Patients with meningitis may be uncomfortable from headache or neck rigidity or lethargic or some mild confusion from fever, but their cerebral function remains intact. In encephalitis, however, abnormalities in brain function are a differentiating feature, including altered mental status, motor or sensory deficits, altered behavior and personality changes, and speech or movement disorders. A patient is usually labeled as having meningitis or encephalitis based upon which clinical features predominate in the illness. However, the distinction between the two entities can frequently be blurred, since some patients may have both the parenchymal and meningeal process with clinical features of both. And so the term meningoencephalitis recognizes this overlap. In viral encephalitis, we also have to distinguish between primary and post-infectious. Viral encephalitis that's post-infectious means that it occurs after the infection has resolved. Primary infection is characterized by viral invasion of the CNS. Neuronal involvement can be identified on histologic examination, which may show inclusion bodies on light microscopy or viral particles on EM. The virus can also be identified by PCR or occasionally cultured from brain tissue. In post-infectious encephalitis, which also goes by the name of acute disseminated encephalitis or ADEM, a virus cannot be detected or recovered and the neurons are spared. However, perivascular inflammation and demyelination are prominent in this entity. The inability to recover a virus and the type of histologic abnormalities observed suggests that post-infectious encephalitis is actually an immune-mediated disease or type 3 hypersensitivity. A wide variety of different viruses can infect the CNS. A common cause of sporadic encephalitis is herpes simplex virus type 1. Other viral pathogens may be suggested by historical clues, including geographic location, such as St. Louis encephalitis in North America and Japanese encephalitis in Asia, and regional outbreaks, such as enterovirus type 71 in Asian Pacific regions. Animal exposure, such as bat or rodent exposure or dog bite with rabies, and specific clinical clues, such as profound weakness and rash in West Nile virus. West Nile virus has been by far the most common cause of proven viral encephalitis in the United States. I'm going to first discuss some general features of viral encephalitis and then discuss some specific pathologic features of HSV encephalitis as an example of sporadic encephalitis and West Nile virus encephalitis as an example of arboviral encephalitis. So here we go. In general, viral encephalitis is characterized by the histologic triad of perivascular chronic inflammation, most of these are lymphocytes, microglial nodules, again a cluster of microglial cells which are histiocytes and lymphocytes, and neuronophagia, which is a dying neuron surrounded by a cuff of lymphocytes. So histologic triad of perivascular chronic inflammation, microglial nodules, and neuronophagia. Herpes simplex virus type 1 is a cause of aseptic meningitis in immunocompetent individuals, generalized encephalitis in neonates born by vaginal delivery to women with active primary HSV infection and a cause of acute necrotizing encephalitis in immunosuppressed patients. Patients may present with fever, headaches, seizures, and mental status changes, which may rapidly progress to coma and death. So, this is a can't-miss diagnosis because of its rapid progression, as well as the fact that there's specific therapy for this. Notable also is that alterations in mood, memory, and behavior are characteristic with HSV encephalitis. Grossly, HSV encephalitis is characterized by bilateral, typically asymmetric, hemorrhagic necrosis affecting the medial and inferior temporal lobes, the insulae, the cingulate gyri, and the posterior orbitofrontal cortices. The brain is usually swollen, and lateral transtentorial herniation is a common finding. This image is a coronal slice, again reinforcing the specific areas that tend to be involved with HSV encephalitis, the temporal lobes, the orbitofrontal cortex, and the insula. Another characteristic finding illustrated by this image, also involving the cingulate gyri, are that HSV encephalitis is associated with hemorrhagic necrotizing lesions. Microscopically, one sees necrosis associated with a macrophage-rich inflammatory infiltrate. Red dead neurons with eosinophilic cytoplasm and neuronophagia are present. The red neurons are indicated by the red arrows, and neuronophagia with the green circle. Even more difficult to identify are the characteristic Cowdery A intranuclear inclusions, which are eosinophilic and surrounded by a halo within the nucleus. These neurons are diagnostic for HSV infection and are present in both neurons and glial cells. This image also shows features that are generally seen with viral infection, including perivascular chronic inflammation and microglial nodules, but the arrows indicate cells with intranuclear inclusions. All right, let's now contrast that with arboviral encephalitis. Most patients with arbovirus encephalitis have a nonspecific flu-like syndrome lasting a few days. These symptoms are followed by seizures, confusion, drowsiness, and meningismus. The arboviruses produce findings typical of any viral encephalitis, including perivascular chronic inflammation, microglial nodules, and neuronophagia. There is also evidence of leptomeningitis in most cases. Most lesions are found in the gray matter, and some viruses, like West Nile virus, have a predilection for the brainstem and spinal cord. By definition, no viral inclusions can be identified. Usually the diagnosis is confirmed by either molecular testing on tissue or serologically by demonstrating appropriate antibodies suggesting recent infection. This section, which is through the anterior horn of the spinal cord, shows increased cellularity of the tissue with perivascular and parenchymal infiltrates of mononuclear inflammatory cells, mostly lymphocytes. This picture resembles that sometimes seen in encephalomyelitis produced by another flavivirus, Japanese encephalitis, as well as infections caused by polioviruses and some other members of the enterovirus family. So it's nonspecific. Again, there's features that are generally seen in viral encephalitis, including microglia and macrophages marking sites of neuronophagia in anterior horn cells. This image better illustrates neuronophagia in the temporal neocortex in a patient with West Nile virus encephalitis. All right, hang in there for a summary of what our take-home points are for this presentation. In CNS infections, we have to distinguish between meningitis and encephalitis, and this depends on the presence or absence of normal brain function. Abnormalities in brain function are what differentiates encephalitis from meningitis. Meningoencephalitis describes patients who have clinical features of both meningeal and parenchymal processes. We have to distinguish in viral encephalitis between primary and post-infectious encephalitis. I've only talked about in this presentation primary encephalitis, in which the virus can be identified or inferred. Post-infections are thought to be immune-mediated and a virus is not identified. There's a classic histologic triad which is general to all viral encephalitis and includes perivascular chronic inflammation, microglial nodules, and neuronophagia. We learned about the gross and microscopic features that are more specific for HSV encephalitis. Grossly, there's hemorrhagic necrosis of limbic structures associated with brain swelling and often herniation. Microscopically, we see, in addition to the general features of viral encephalitis, necrosis, macrophages and eosinophilic neurons, sparse perivascular inflammation and microglial nodules, and Cowdery A intranuclear inclusions or identification of the virus by special stains or PCR. You learned about West Nile virus encephalitis as a prototype for arboviral infections. Microscopically, we see perivascular chronic inflammation, microglial nodules, and neuronophagia, the classic histologic triad, and no viral inclusions. The diagnosis has to be confirmed by serological or molecular methods. So hopefully after these presentations you are singing along with these folks and are comfortable with CNS infections. Thank you.